morning, and welcome to the Radcliffe Institute for Advanced Study. I'm Liz Cohen. I am Dean of the Institute, and I'm delighted you could join us for day 2 of Who Decides? Gender Medicine and the Public's Health. As an Institute for Advanced Study, we do many things. We host 50 fellows annually who pursue cutting-edge scholarly research and bold artistic projects. We support the Schlesinger Library's acquisition and processing of new collections to help scholars and students write more compelling histories of American women, gender, and society. We convene faculty from across Harvard and give them the resources to launch new, often interdisciplinary research initiatives. And through our lectures and conferences, we share much of this new knowledge with as broad a public as possible. Each spring, we organize a conference that probes an issue of broad public concern that is not often thought about in terms of gender. We chose this year's topic because, despite all of the recent debate surrounding the passage of the Affordable Care Act, we at the Institute felt that important questions remain to be asked and answered about the gender dimensions of health, illness, and the provision of medical care. The fact that a large and diverse audience has gathered here today to share in this discussion confirms our view. We expect to be joined over the course of today by faculty and students from over 30 colleges and universities, including schools of public health and medical schools. 25% of our registrants are students. A diverse group of stakeholders and observers is also present here today, including lawyers and journalists, social workers and psychologists, doctors, nurses, and allied healthcare professionals, and theologians and health policy advocates. And of course, we are all medical patients. Many kinds of people clearly care about probing who decides and considering how we as a society might make different and better decisions about the public's health. And our audience extends beyond this room. We are live streaming today's proceedings, and we extend a warm welcome to our online viewers. Whether you are with us at the Knaufel Center right here or watching from a distance, you can join the conversation on Twitter with the hashtag #WhoDecides. I hope that many of you were able to join us last night for Eve Ensler's amazing presentation and her stimulating discussion with Diane Paulus, the artistic director of the American Repertory Theater. Eve conveyed how much our personal experiences of health and illness are deeply influenced by our own personal histories. But at the same time, individual experience with disease and medical care is profoundly shaped by larger structures, including political power and social institutions, cultural attitudes, and the availability or not of economic resources. 2 recent events have reinforced our view that the relationship between gender and health is deeply embedded in a society's most basic structures, making change challenging. The first was a lecture that took place right here at the Institute recently. The second is a story that has received extensive news coverage in the United States. 2 weeks ago, we welcomed biostatistician Huda Zurek to the Institute to deliver the annual Rama Mehta Lecture on Women in the Developing World. Professor Zurek has devoted her career to improving women's health in the Middle East. Her account was striking. Women in the developing world face a combination of poverty, patriarchal culture, and illiteracy that makes being female a health risk. Zurek's cure? Education. Education because education, she argued, ultimately increases economic opportunity and gender equality. When women and girls are valued, they gain many benefits, including better access to medical care and improved health. Nor are women in the industrialized West immune to political and economic obstacles to health delivery. Consider the case now before the US Supreme Court. Hobby Lobby, a corporation, argued that it was exempt on religious grounds from providing women with a full range of contraceptive choices as required by the Affordable Care Act. The court's decision, due out this summer, will determine if employers can limit women's private health care choices. Two very different examples, certainly, but with a very similar point. Health is rarely only about health alone. That is why when we mapped out today's program, we wanted to take you through the range of larger forces that influence individual men and women's personal health. So we will begin this morning by examining the role of gender in defining some of our most basic assumptions about health and disease, including how social expectations for male and female behavior produce different health risks for men and women. Then this afternoon, we will ask how gender determines which diseases get studied or not, which diseases are in the public eye or not, and which drugs get developed or not. We will end the day by examining how the Affordable Care Act might present opportunities for greater gender equity in health insurance coverage and more equal access to medical care. Finally, I want to thank everyone at the Radcliffe Institute for making this conference possible. It has been an enormous undertaking involving staff from every department. Now it's my great pleasure to introduce Janet Rich Edwards, who has played a crucial role in conceptualizing and organizing this conference. Janet is Associate Professor of Medicine at the Harvard Medical School and Associate Professor of Epidemiology at the Harvard School of Public Health. She is also Director of Developmental Epidemiology at the Connors Center for Women's Health and Gender Biology. Janet is a proud Radcliffe alumna who has returned to Radcliffe Yard this year to direct the Biological Sciences program here at the Institute. I am very grateful for Janet's deep commitment to this topic and to making this conference an engaging and important event. Thank you, Janet, and it's your turn.
Thank you, Liz, and thank you, everybody, for being here. This is a great turnout, and I'm really excited about this day. I think it's going to be thought-provoking, and I really invite you to come up and ask questions, because that's what really brings it alive. So the subtitle to this conference is Gender, Medicine, and the Public's Health. And I've been asking myself, there's probably not a few of us who said, you know, she was kind of stuck with gender because it's the gender conference. Maybe this should have been sex differences, medicine, and the public's health. And I wanted to argue to you that no, it really is gender we're talking about here. That while we know of biological sex differences between men and women, very often it's our gendered experiences of the physical and social environment that interact with our bodies and get expressed as our health and disease. I'll try to illustrate this. So if you think about what sex means, usually this is sort of a strict biological determinism that we're talking about. You know, it's about whether you're female, you're male, you're XX or XY, and we often say in this context, every cell has a sex, and that is true. But in reality, the sex differences are really more like gradients or continua. So when you think about hormones, for example, you sort of think about male hormones and female hormones, but all men have estrogens, all women have testosterone. These are really overlapping distributions that vary greatly within men and women. When we think about gene expression, which we know also varies between men and women, and when I talk about gene expression, I'm talking about the ways in which your DNA are coded into proteins, which form your cells, which form your tissues, which form your organs, which affect how you even perceive the world and behave. That these, while they vary between men and women, vary much more within women and even with an individual over their lifetime. We think about body size, obvious body size differences between men and women. And in fact, here again, we know there's quite a bit of overlap between the sexes, and something almost ironic, it's almost one of the most obvious sex differences, but we don't pay enough attention to that. Witness the FDA's recalibration of Ambien in recent weeks, having the dose for women so that we aren't taking the same dose as men anymore. And finally, pregnancy, which you can argue is clearly a uniquely female domain. But even here, the experience and the course of pregnancy vary so much between women and between societies that you can hardly call this a black and white difference. Now let's think about gender, which maybe is more along the lines of what we consider masculine and what we consider feminine. And one of the obvious things here is behavioral norms, right? The way girls and boys or men and women play, what they eat, what risks they take, and what sanctions they experience when they step outside gender norms are a very powerful part of what gets into our bodies. Certainly healthcare has strong gendered aspects, and we'll be talking about that today. Gendered aspects of who takes care of whom, who are the providers, and how do we receive our medical care? What kind of access do we have? Occupational hazards are another strongly gendered factor that gets into our bodies throughout our lives and affects our biology. And finally, social status. We know there are great differences in social status between men and women around the world. It doesn't always mean the same thing in every place. But almost everywhere, social status drives the three big drivers of health: education, poverty, and violence. We'll be talking about that today, too. So you see here we've got sort of issues of sex and gender intertwined, and I would put to you, it's actually more like a big, messy, entangled ball of yarn. It is really hard, many times, to distinguish sex from gender effects. So we have Nancy Krieger here at Harvard saying that we are essentially biologic expressions of gender and gendered expressions of biology. And I'll give you some examples. So in most places, lung cancer rates are higher in men. Now you could sort of say this is a sex difference, but really we know this is driven very often by societal attitudes about smoking, where that cigarette smoking is often seen as a marker of masculinity or virility, while it's frowned upon for women. Here in the United States, sexual abuse of children is prevalent. It's more prevalent among girls. And here in the US, it's a rather strong correlation between having been sexually abused and becoming overweight or obese by young adulthood. That, of course, sets these young women on a different trajectory for life, for chronic disease. A male social role, male as protectors. After the Chernobyl accident, there were about 800,000 liquidators, they were called, who went in and cleaned up the mess. These men were exposed to a lot of radiation, and right now it's looking like they have 3 to 6 times higher rates of thyroid cancer. That is definitely coming from their gendered male role as protectors. Here's another example, one that many of us are familiar with. In some places, women can't get permission to go alone to a clinic. So a woman with a sexually transmitted infection, perhaps because she couldn't say no to a condom, or she couldn't insist on a condom, will go untreated, may lead to infertility. So this is a way in which her gender role is literally incorporated into her physiology. And if we didn't ask the right questions, we might miss that gendered aspect. And finally, parents who work the double shift, and this could be men or this could be women, the double shift of having a full-time job and full-time childcare have been shown to have higher stress hormone levels even on the weekends. So before I started really thinking about this conference and this talk, I always thought of malaria as one of those equal opportunity diseases. Here's an annoying mosquito for you. She is female, by the way. I have no idea what her gender is, but she is female. Only the females bite. The males, it turns out, get to sip plant nectar. If you are bitten by a mosquito as an adult, non-pregnant male or female, your chances of getting malaria are exactly the same, right? So it's more about how many mosquitoes you're bitten by. However, if you're pregnant, the immune adaptations of pregnancy make you much more vulnerable to developing malaria, and severe malaria at that. You're vulnerable to anemia during the pregnancy, higher risks of miscarriage, stillbirth, and delivering preterm, all of which mean you may end up childless, which has its own social implications in many societies. We also know that malaria is transmitted vertically. That is, the parasite gets through the placenta, so children can be born with malaria. And we also know that children who develop malaria suffer cognitive deficits and delays in school. So that you can imagine there's something of a vicious cycle going on here. Your chances of getting malaria are greater if you're bitten by more malarial mosquitoes. So occupation is a very important determinant of your risk of malaria. So very often men are working in fields and are highly exposed to the malarial mosquitoes. But there are also places where women are exposed. They're tending their gardens at dusk, right when the mosquitoes come out, or they're washing clothes by the edge of a pond that's breeding mosquitoes. The best way to prevent severe malaria and malarial death is early treatment. And that's usually the domain of the local health clinic. So when somebody develops malaria and they start getting the cyclic fevers, they should go to the health clinic and get some treatment. So men in general have enough money and autonomy to decide to go to the local clinic. On the other hand, if they have a job where they can't take a day off without fear of losing that job and they are the providers for their family, they may never get to that clinic. Women have this sort of double burden where they're very often taking care of the whole family. In fact, they're responsible for the health care of everybody in the family. How do they balance the needs of one family member against another versus their own health? You sort of get these scenarios where women will need to walk 5 miles to get a clinic with a baby on her back and a feverish child in her arms. And you can imagine what a barrier that would represent. Also, very often women need to get permission to go to the clinic, either from spouses, from older wives, or from elders in the community. They may not get the permission, and they may, in fact, be diverted to the local healer, the traditional healer, and miss out on the appropriate treatment altogether. Bed nets are one of the two really effective preventive measures. They're treated with insecticides, but usually it's only one net per household. So then there becomes the question of who sleeps under the net. The men may be sleeping outside, so you might say, well, they should be under the net because they're more likely to get bitten by the mosquitoes. But on the other hand, it's women who are sleeping with the children, and the children are the most vulnerable to malaria, so perhaps the women and children should be under the net. So there's another gendered aspect. The other big program for preventing malaria is called indoor residual spraying. And that's where they come in and they sort of spray the walls of your hut or your home with insecticide. It sounds kind of awful, like none of us would ever want to have it happen, but it's actually quite effective when you think of the choices. Developing malaria is a pretty bad option. So very often, the workers who are trained to go around and spray are men. And very often, they arrive at the household compound where there are only women home. And the women can't let the men into their homes unless there's another family member there, for fear of sanctions from the community for inviting strange men in. Finally, when somebody in the family gets really sick and needs to go to the hospital, that is often a very expensive decision for a family. And you can imagine that issues of cost, of distance, of who's expendable in the family or not are very gendered decisions that affect the extent to which people get appropriate care during a crisis of malaria. And lastly, this is a very clever study that was done about a year ago. It's written up in Science from the School of Public Health, where using cell phones, they managed to track which people were acting as vectors of the parasite. So we're actually sort of hosts or carriers of the parasite. And they found that men, transport workers, around Lake Victoria, which is a highly endemic area for the malarial mosquito, as you can imagine, were actually bringing the parasite to Nairobi. So there's even gendered aspects of how the disease gets spread around a country. So from what looked at first glance to me anyway, equal opportunity disease, I think you've come to realize that if you want to eradicate malaria, you had better take gender into account. And that's what we're going to do today. Today, as Dean Cohen described, we're going to ask, how does gender affect how we define health and disease? That's the topic of our first panel. How does it determine our research agenda? And finally, how does gender drive healthcare policy and access?